Dear friends, good evening Bangladesh, good evening India, good afternoon Europe, and good morning United States of America. Friends, this is the 6th skill development course of the Society of Minimally Invasive Cardiovascular and Thoracic Surgeons of India. We started first course in 9th of February with minimally invasive mitral valve surgery, which followed by minimally invasive aortic valve surgery, coronary surgery, thoracic aorta, surgical treatment of heart failure, and we are today going to discuss management of cardiac arrhythmias. The scientific committee included Dr. Anvay Mule, Rajneesh Malhotra, Satiki Nambala, and Ajit Bana, and all the executive members of the society. Today, really, we are thankful to have a 3 galaxy of speakers with co-moderator Dr. Mahesh from Germany, who is going to take over and introduce the speakers. But before that, let me also introduce to you our panelists. We have Dr. Anil Saxena, who is the Executive Director of Pacing and Electrophysiology, where he is working since last 32 years. I had the opportunity to work with him. He is a renowned expert in the management of cardiac arrhythmias by catheter ablation, and he is one of the pioneers in biventricular pacing. Dr. Saxena has served on various guidelines and consensus document writing committees and is a regular faculty in international and national conferences. He has served as a president of the Indian Heart Rhythm Society. His current position includes Associate Editor, Pace Journal, Chief Editor, APHRS Newsletter. He also serves the editorial board of various local and international journals. Welcome, Dr. Saxena. Then we have Dr. Kartikeya Bhargav, who is the Director, Electrophysiology and Pacing, Heart Institute, Vedanta, Medicity. He is a gifted electrophysiologist. I had opportunity to work with him in Fortis Scott Heart Institute for a long time. Then we have Dr. Prasanna Simha, who is a professor of the Department of Cardiothoracic Surgery and Vascular Surgery, the famous Sri Jayadeva Institute of Cardiovascular Sciences and Research, Bangalore. Welcome, Dr. Prasanna.
Hi.
We also have Dr. Prashant Chandra, who is a senior consultant, the Department of Cardiac Surgery at Square Hospital Limited, Dhaka. He has 20 years of experience and is skilled to perform a wide array of cardiac surgeries like beating heart cabbage, minimally invasive cardiac surgery, redo cardiac surgery, aortic surgery, especially Bental, David's, aortic arch, Trojan elephant trunk. He is one of the pioneer of minimally invasive and aortic surgery in Bangladesh. Welcome, Dr. Prashant Chandra. Now, over to Dr. Mahesh to take up the proceedings and introduce the speakers. Over to Dr. Mahesh, please.
Yep.
Thank you.
Hello. Yeah, it's my privilege and pleasure to introduce Professor Nicholas Doll to this august gathering. Professor Nicholas Doll has done his medical studies at the University of Göttingen, followed up by surgical training at the University of Hamburg and at Leipzig Health Center. He has been a part of the pioneering group of cardiac surgeons practicing minimal invasive cardiac surgery and ablation techniques for the last 2 decades. He is now currently holding the position of director and chief of cardiac surgery at the 3rd largest center, the Schustermann Clinic in Germany. Interestingly, his PhD is on experimental evaluation of different surgical ablation techniques for the treatment of atrial fibrillation, which was completed in November of 2004. His main interests are surgical ablation of atrial fibrillations, pacemakers, defibrillators, biventricular stimulating techniques, op-cap surgeries, and also minimally invasive surgeries, where he is a doyen in the German group of surgeons. And he's also interested in diving medicine. Yeah, over to Professor Dahl. I request your good self to take over.
Yeah, thank you very much for this very kind introduction. Dear Dr. Mishra and dear panelists, it's really a great privilege and honor to speak today. And I think it's very nice that we also have electrophysiologists in the panel, and I hope that we will have a nice discussion and that we can talk and find some intersection sets in between surgeons and cardiologists. So I would like to share my screen over with you.
Sie haben die Bildschirmfreigabe gestartet.
And I hope that you can see my first slide. So it's great to talk about my own ways, but it's not only my own way, it's the way of many pioneers and friends. And I appreciate very much that Randy Wolf, who's also one of the pioneers, is joining today. And we did basic experimental work on energy sources, and also my friend Piotr Zawalski, with whom I performed many ablations in procedures in Leipzig. So I would like to start with the godfather of the surgical treatment of atrial fibrillation. Jim Cox, he developed the Cox-Maze 3 design almost 3 decades ago. And he used at that time the so-called cut and sew technique. And his aim was to fragmentate the left and the right atria into many pieces. And his idea was to eliminate all hypothetic biatrial reentry circuits. And the advantage of these techniques were very high cure rate of more than 90%. Long-term efficacy was proven in many publications with follow-up of more than 10 years. But this very aggressive procedure has had also shortcomings. It was challenging and it was not reproducible for everybody. The requirement of cardiopulmonary bypass was for all patients, and it had a cross-clamp time of at least 60 minutes and also morbidity of pacemaker implantation. And due to this fact, we all tried to replace the aggressive knife with alternative energy sources. And we tried to mimic the cut with unipolar radiofrequency devices. And we started in 1998 in Leipzig, and we performed AF ablation in almost 400 patients. And in that time, we also started with minimal invasive surgery for the mitral valve. And we used this access for the procedure, and we learned a lot from the electrophysiologists who joined us in the OR. And we had at that time 160 patients treated as a standalone procedure for paroxysmal atrial fibrillation, most of them. Only 40% were permanent. They were young, left atrial was a bit enlarged, and they had a 6-year history of atrial fibrillation. And these patients, they had excellent results, also long-term results, more than 80% with a small incision in the right fourth intercostal space. But we have seen after a while in 2001 that we have induced esophageal perforations. You can see on the CT scan here, the air, here's the esophagus located and the gastric tube. And here you can see the device which we have used. It was a 1 centimeter reusable dry unipolar radiofrequency device. We call this study ERAF. And due to the pressure, we had direct contact to the esophagus, and we we induced these dramatic esophageal perforations in these patients. The consequence was that we stopped it immediately and we switched to cryoablation. We thought at that time that cryoablation was a well-known energy source and is more safe. And it was my job then in Leipzig to go back into an animal model. And here I met Randy Wolf, and we have ablated many sheep, 70 female sheep. And we used all these different energy sources from endocardial and epicardial on bypass and off bypass. It was a quite nice setup here in the Leipzig facilities in the animal lab there. And we were able to reproduce the pathomechanism of the esophageal perforation, and we have seen that the dry unipolar radiofrequency device was dangerous and was able to destroy esophageal muscle layer. And here you can see on the histology. And this is the whole summary of the story. And we could find that bipolar radiofrequency devices are very effective and very safe because the energy deliveries from one jaw to the other, and we were not able to harm adjacent tissues. We could see endocardial damage and also thrombus, and that was the sign that this lesion was transmural if we apply energy from the epicardial aspect. We also could see that cryo from the epicardial aspect was not that effective due to the current blood flow. We could see a rewarming of the tissue, and on a beating heart, cryo-epicardy was not effective. Unipolar cooled was also effective and is still used in the world. And cryo, the endocardial cryo is meanwhile standard, very effective, very nice lesions. And the surface is without any thrombus at the end. So this is our standard device in the end. So before 2000, Cox started with the cut and sew technique, and we have used many energy sources. And these are the three sources which are left today on the market. And these are the recent data from Germany. In 2020, we have ablated almost 4,300 patients in 78 units out of more than 90,000 patients, and the ablation amount was 4.6% per cardiac surgical patients. And here you can see it's more than 1/3 cryo, more than 1/3 bipolar, and this is the cooled radiofrequency, and here these are other devices. If we look into the STS database, this is a quite old publication from GAMI, but it's still interesting because we know that the overall prevalence of AF patients in our cohorts of cardiac surgical patients are more than 11%, and the treatment is only 4.4%. And this means at the end that this disease is undertreated. We all know that we do not have to ablate all of them, but 4.4 is way too low. If we look into the subcohorts, then we know every third patient with mitral valve disease suffers from AF, 14% with aortic problems, and just 6% patients with who needs bypass surgery. And the treatment here, and this is quite interesting, every second patient with mitral valve disease is treated and the AF is corrected. The aortic, every third patient, and the CABG, only every fourth patient. And my understanding is that surgeons like to treat the mitral valve plus ablation because we all know that the outcome is the best because we do have a volume load of the left atrium. And if the mitral valve is corrected, we know that without any ablation, more than 40% are in sinus in the long-term run. So if you add AF ablation, then you can reach a success rate of up to 80%. This is not possible if you treat patients with coronary artery bypass grafting. The result is not better than 50%. So what is the rationale to treat atrial fibrillation in mitral cases? And this is also from the STS database, 88,000 patients, and they looked into subgroups in this registry. And here you can see the mortality in the group of patients who had no AF and surgery for the mitral valve. They had a mortality rate of 3.7. The group with mitral valve and atrial fibrillation and treated with atrial fibrillation, they had the same mortality. But if we look at patients who had mitral valve disease and received no surgical ablation, the mortality rate is double, 6.7. So this is a sign that we have to do something on the mitrals if patients suffer from atrial fibrillation. This is our lesion set. So this is the lesion set on the left side, which was recommended from Jimmy Cox. And I'm quite positive and feel confident if the right atrium is small and if we do not have any pathology on the tricuspid leaflet, then it's enough just to treat the left atrium with these lines, and you can find in the literature outcome rates around about 80%. So this is also STS published in 20,000 patients collected from 8 to 15. And here they looked at CABG patients and valve patients, all valve and in combinations. And here you can see that all patients who received surgery for atrial fibrillation, they benefited and they had better survival in all cohorts. And this was a propensity score matched analysis 2 years ago. This is also now all patients, STS again, 86,000 patients, again, propensity score matched. And here you can see that the mortality and also the stroke is reduced if you treat these patients for atrial fibrillation surgically. And these data, they induce the change in the evidence. And we can see here that we have a growing evidence for concomitant mitrals, for combinations with the aortic valve. Also the standalone procedures, they have meanwhile evidence, and the treatment of the left atrial appendage. And here you can see the STS guidelines from 17. They said that the recommendation class for mitral valve surgery is 1A for the treatment of atrial fibrillation, and all the others, they have 1B. So today, there is no excuse not to treat atrial fibrillation. And the most recent guidelines from 20, the European ESC guidelines, they said that we have for concomitant a 2A procedure recommendation, and for thoracoscopic, including hybrid, we have a 2B, and the same for the treatment of left atrial appendage. So what are the predictors for recurrence? Of course, if you have a huge left atrium, your outcome will be worse. And our cutoff point is in average 6 centimeters. But you can see here, also if you have a very, very big left atrium, you still have success rate. So also here, no excuses. If you have a huge left atrium, which is calcified, and if you do not have any muscle layers, then you can say, okay, so the decision is always very individual, and I prefer always to discuss this in a heart team. Another predictor is, of course, the duration. But here you can see it doesn't really matter if you have 1 year or 10 years. After 20 years, the freedom from recurrence will decrease, but also we have success rates when patients suffer more than 20 years from atrial fibrillation. This is a publication from Sid Gaynor. So the lesion set is according to the pathology. And we know from Hazaguer that if you suffer from paroxysmal atrial fibrillation, we do have focal triggers in the pulmonary veins, and an isolation of the pulmonary veins is enough. And this is really a very easy, straightforward procedure of pump and also minimal invasively. Randy Wolf is one of the biggest worldwide pioneers in these minimal invasive techniques. If you suffer from non-paroxysmal, that means long-standing persistent atrial fibrillation or persisting atrial fibrillation, you have a very complex pathology. You have rotors, and then just the isolation of the pulmonary veins is not enough. So you need additional lines, and then you have to perform a Cox-Maze 3 is the cut and sew, and the Cox-Maze 4 is with alternative energies. That means with cryo or bipolar energy sources. So we do have the biggest intersection set in these patients who suffer from standalone atrial fibrillation, and I would like to share with you a life in a box case how we treat standalone atrial fibrillation and where I see the future together with the EPs. So this is a life in a box case of a 55-year-old with long-standing persistent atrial fibrillation. The heart was fine so far, and it's a complete thoracoscopic 3D approach. And you can see here from the right side, the right pulmonary veins, and this dissector, the name is Wolf dissector. It was designed by Randy as well, goes around the right pulmonary veins, and then we pull a red rubber through, and then we have a nice and safe guiding for our bipolar clamp, which will be introduced through a 1 centimeter hole in the 4th intercostal space. And then it slides around. And here it's very important that, that we ablate the left atrium and not directly the pulmonary veins, because hypothermic energy can induce stenosis. We have never seen stenosis because the device, the shape of the device does not allow to ablate the pulmonary veins. And you can see on the monitor the impedance and the energy. And there is an algorithm. If the impedance is high, the energy goes down, and that indicates transmurality. In our animal setup, we could see after 1 ablation transmurality. And then we check it, and this is very important, especially to be accepted from EPs, that in all of our procedures, we confirm a bidirectional block and pace and measure the pulmonary veins after the ablation. Addition lines from this side will be performed with a linear, also bipolar device through the transverse and oblique sinus to create the superior and inferior box lesion, which you can see from the left side, which will be completed then. Now we're on the left side, and this is the bipolar device. The pulmonary veins are already isolated, and with this device, we complete, in this case, the inferior box line. You can see the line coming from the other side. Then we measure again. Patient is now in sinus rhythm converted spontaneously, which is a good sign for the whole procedure. Here you can see by pacing the pulmonary veins, a confirmation of the block. And the last step is the closure of the left atrial appendage, which is a part of the AF surgery. The isolation of this area is also described by Cox and very important, and we will see if this is also a procedure when Laos will be published, hopefully this year, to prevent stroke. But we could see in all our cohorts that stroke is not anymore any problem if the left atrial appendage is really closed. And it's echo controlled, how you can see. We do have echo online that there is no remaining stump. And here I'd like to demonstrate that the left atrial appendage is closed and it's hemostyptic because the pressure is so high that you can decompress it and just open it.
Dr. Trasantakanda hat das Meeting verlassen. Dr. Trasantakanda ist dem Meeting beigetreten.
And this is also confirmed in publications that this is an electrical isolation. And these are my results from Stuttgart. I'm now in Bad Rotenfelde, and we have also ablated more than 200, but these data are published. Meanwhile, it's 273. Left diameter is a bit enlarged. Main of these patients had persistent and long-standing persistent, and every second had failed catheter ablations. And the paroxysmal, we are not allowed as surgeons today to ablate paroxysmal atrial fibrillation, but these, they had all failed catheter ablation previously. And here you can see the lesion set. So this is almost the same, I think. EPs are performing with their point-by-point catheter ablation. And the results are very nice. We have no mortality, and this is important because we are not allowed to induce major complications in a disease which is not life-threatening. We have seen one early stroke that was an air embolism, and no late stroke in a 5-year follow-up. We had one patient converted to sternotomy due to bleeding. And you can see here the dip after a while, and then it goes up. And I would like to explain why we have seen this. Cosmetic result is fine. And here, for us, it's quite difficult to produce a complete transmural linear line via the roof. And here you can see a gap. And this gap was fixed by EP. And this was a nice and quite straightforward procedure. So all failures, most of them had recurrent AF. Some of them had a typical flutter or atypical residing from the left atrium. But after a touch-up, 74% were back in sinus in these kind of hybrid procedures. And this is one of our patients who went back in the EP after this, we call it TT MACE procedure. And here, the catheter is in the pulmonary vein, and then the EP is measuring, and he confirmed a bidirectional block. He hasn't seen any signs, and when he is pacing here, there is no conduction to the left atrium. And now we move to the posterior wall, and here is also no signal, then pacing, and no conduction. So the whole area here is also isolated. And this is quite interesting. Then he performed a voltage mapping. Gray means it's no activity. So this is completely isolated and dead. And purple means healthy myocardium. And here you can see the gap. And the rest of the atrium is completely healthy. And we were able to isolate the pulmonary veins and the posterior wall. And in this patient, they could see a focus on the right side, close to the superior vena cava. They put some ablation spots there, and the patient is still
Dr. Trasantakanda hat das Meeting verlassen. Dr. Trasantakanda ist dem Meeting beigetreten.
The postoperative management is quite important. We need antiarrhythmic drugs based, of course, to the rate and the rhythm. We try always to avoid implanting pacemakers, so you have to be patient at least 2 weeks. The anticoagulation is based on the Chart-Swartz score and on the quality of the left atrial appendage closure. If you have a remaining stump, then you still need to continue your anticoagulation therapy. Cardioversion is quite aggressive in our cohorts. Every 4th patient is cardioverted during his hospital stay. And we know that in the left atrial appendage, ANP is located, and these patients suffer from fluid retention and pleural effusion, so they need diuretics for at least 2 weeks. So this is one publication from published last year, the CASA-AF, and this is quite poor outcome. And this is a randomized trial which focused on long-standing persistent atrial fibrillation, the challenging patients, and everyone did this on his own, surgeons and EPs. And you can see the outcome is very poor, just 30%. Randomized, 120 patients, long-standing persistent, 1-to-1. And what is the conclusion out of this? I think we should do together. And there is a hybrid approach. The pioneer for the hybrid is Marc Lamer. And these are just some patients 10 years ago, and he could show that if you perform a hybrid approach, so EP and surgeon together, you have better outcomes. But what does it mean, hybrid? Is hybrid just a battery on wheels? Or is it a nice car from Stuttgart? Or is it an EP and cardiologist together? And we tried to find out, and we initiated a randomized prospective European trial, the so-called CASA-AF trial. And we
Der Host hat Ihr Video für alle sichtbar gemacht.
We had 180 patients meanwhile. We enrolled patients for a 5-year period, and I hope that we can publish this next spring. And the idea was hybrid against catheter, just catheter, in long-standing persistent patients or patients with enlarged left atria. And the follow-up time after blanking period should be 3 years. And this is a quite interesting study, and we all hope that we can show that we are together better and stronger to treat a long-standing persistent atrial fibrillation. One quite interesting approach, this is also 10 years old, but now it's again on the market, because with this device, the surgeon can ablate the posterior wall, which is difficult for EPs, because EPs are afraid to damage the esophagus. But this is safe. It's a unipolar, but it has a sucking device. And but at the end, it's an incomplete procedure, and you need to complete everything with a touch-up, with an endocardial touch-up. And it's not a thoracotomy, it's a side-suffit approach. You can see a big cannula going into the pericardium. And then through this cannula, you can ablate the whole posterior wall and the dorsal aspects of the pulmonary veins up to the pericardial reflection. So this must be discussed in a heart team, and these patients, they all need a touch-up by the EPs. So this is a combined epicardial and endocardial approach. You can see the result on the left upper picture. Is pre-ablation, then post-epicardial ablation, and here you can see that it's incomplete. And after endocardial ablation, you can see that the whole posterior wall and the pulmonary veins are gray again and isolated. And these are the first results. They suffer all from long-standing persistent, and the efficacy was 84% after 1 year in these quite small cohorts. And now
Dr.
most recent study
beigetreten.
was published in December 20, and this was a prospective randomized control multi-center trial in the UK, and 153 patients were randomized, 2-to-1 randomized in this setup, and it was the hybrid conversion against just catheter ablation. And you can see here that the freedom from atrial fibrillation with and without antiarrhythmic drugs was significantly higher with a hybrid convergent versus just endocardial ablation alone. And this is a sign, not that much patients that we should do together. And then this last year published HeartCap shows exactly what I did in the C study. Only 40 patients, and they were randomized hybrid, and this hybrid means the TT maze plus ablation. And here you can see if you go for a hybrid, the amount of sinus rhythm is much more higher, and patients benefit, and compared to outcome 45–50% if they are treated just with catheter ablation, and all again long-standing persistent atrial fibrillation. So in summary, I would like to say there is a significant patient population who is challenging to treat by endocardial catheter ablation. Epicardial bundles play a role in progressed AF. There is evidence that epicardial ablation increases the success. This is not associated with an increase in severe events, and a hybrid approach is beneficial for challenging patients with long-standing persistent atrial fibrillation. So this is from Jim Cox, and he said in 2021, we must have a valid reason for not performing concomitant AF surgery in patients with a history of AF who are undergoing CABG mitral or aortic valve replacement. Otherwise, we are not providing an acceptable standard of care. So at the end, it's always our perspective, which is very different. And patient said, yeah, I just want to have a pill in the pocket. And the EP said, yeah, a catheter ablation is fine and you're awake and it's just a little puncture. And the surgeon said, yeah, I can fix it, but I'm more aggressive. But at the end, you need a team and you need a good approach. You need the correct device. Otherwise, you're not able to reach the aim to cure atrial fibrillation. And here you can see it's the wrong device for a strong man. And thank you very much for your attention.
Der Host hat Ihre Freigabe beendet.
Okay, now I'm open for questions. Thank you very much for listening.
Absolutely super. Professor Dahl, thank you. Thanks for your great presentation. Let me now invite panels to discuss and put the questions to Professor Dahl, starting from panel.
I must first of all compliment Dr. Dahl for a wonderful presentation and his brilliant exposition of various new technology, very fascinating approaches to managing atrial fibrillation patients, particularly when those who are undergoing cardiac surgery. So obviously, we all agree that the main challenge is trying to find the transmurality of the lesion. And I think in the operating room, it might become even more difficult because in the EP lab, we now have some new technology which can rapidly map the LA left atrium, and we can quickly identify the gaps in transmurality of the lesions. So how do you do that in the operating room? Because that is a main challenge. Even if you are established that the pulmonary veins are not disconnected by pacing, how do you in the operating room find the location of the gap?
Yeah, thank you. That's a very good question. If we treat standalone patients, we always map these patients. So we map and we can see what you have done before. And then we have always the same strategy for our ablation, but it would be very nice if we have mapping before and then we really know what to do. We do not have this. We know from Jim Cox that his separation and his Cox maze for approach is very sufficient. They have no strokes and high cure rate. And if patients are on pump with cardiac arrest, it doesn't make sense to measure afterwards because we have circumstances which do not allow to measure because we have fluid in the heart and the heart was arrested before. So normally we do not measure. In all beating heart patients, we do this and it's very important. But if we perform cryoablation in mitrals, we are not able to do it.
Yeah, because the cut and sew approach of the original approach was obviously it would ensure transmurality, but the usage of new energy sources like cryo or even RF cannot ensure transmurality at that time, and a subsequent procedure may be required.
Yeah.
Have you noticed any
So
increase in complications if you combine the RF with the surgery, mitral valve surgery or aortic valve surgery? Does it lead to increase? Because obviously the procedure duration will increase. Does it translate into increased complication rate as well?
No, the answer is easy. No. There are many publications, and if you go through the STS database, we improve outcome, we reduce mortality and strokes, and it's not dangerous today. 20 years ago, we have had these esophageal perforations, but there is no addition morbidity due to atrial fibrillation surgery today.
Could I make a comment, please?
Yes, please.
I think it's very, very important that we treat atrial fibrillation. One of the worst things that you can have after surgery is a patient with fast ventricular rate, having the heart rate going up, BP coming down, start giving negative inotropic drugs. So I think it's without doubt that today in 2021, you should attempt to do the MACE. Another thing that I would like to draw attention to is, even if the MACE is failed, usually the rate is controlled. Even in a failed MACE, we generally see that these patients don't have a runaway rate. And that's something which is, even though you may have to sit with the EP people after some time to complete the MACE, usually they're not having, or they're far more easily managed. So those are two important things. Another thing that we do is, as you highlighted, is we have we have to take care to ablate the appendage thoroughly and confirm it on RTE at the time of surgery. And that in itself gives you a significant benefit also perioperatively. We can reduce the amount of strokes too.
Right. So, Dr. Dole, the question, the point put by our friend is that even though you may not achieve a sinus rhythm, you can control the rate. What is your comment? Yeah. I think the sinus rhythm is really important because that enhances the cardiac output, and just reducing the rate is going to fulfill the objective of treating atrial fibrillation. Your comment, please.
Yeah, so sinus rhythm is hemodynamically the ideal situation. A good heart rate is also okay. If a patient early postoperative is very fast, that is really bad. We must differentiate between normal postoperative atrial fibrillation, which is completely different, to a recurrence of AF after AF treatment. And we see in the first week the normal post-op AF, and these periods are still quite fast. And that's why we cardiovert them very early and aggressively. We put them on amiodarone, we give them beta blocker, and every fourth patient needs cardioversions in the early postoperative period. So I think it's essential to go back to sinus rhythm. Otherwise, the atria are not able to reorganize and to have a stable sinus rhythm on the long-term run.
Karthikeya, you want to highlight?
An excellent presentation. I have a couple of questions. One is that in patients where we do endocardial RF ablation, we find that patients who have recurrence, the most common cause is reconnection in the pulmonary veins, and in certain other patients, there may be other triggers, non-pulmonary vein triggers. And what in your experience is that when you do standalone surgical ablation for our atrial fibrillation, and those patients, when they develop recurrence, what is the most likely cause in them? Again, is it the same pulmonary vein recurrence? And how often do you need to do it again surgically, or it's always manageable by electrophysiologist endocardially?
Yeah, so we do not have the option. If we treat standalone AF with the TT MACE, it's just a single shot, and we are not able, due to adhesions, to do it again. we always map these patients, and they all had today previous catheter ablation. And it's very interesting to map them. And I map them, if it's possible, with my EPs together. And we made the experience that if they had previous cryoablation with the cryoballoon endocardially, the pulmonary veins are mainly isolated. So I'm always able to confirm bidirectional block. The unipolar point-by-point ablation is able to isolate the right side very sufficiently. And on the left side, in almost all cases, the left upper is open because the ridge between the left upper and the left atrial appendage is difficult to manage for you. And I always see gaps there. And that's why we always ablate them. And our ablation is far on the left atrium and not on or in the pulmonary veins. So I isolate a big area in which a lot of ganglionic plexi are also located. Did I answer your question?
And anyway, stay entire session so that you can have some more question and answer sessions. So now over to Mahesh to introduce our next speaker, which is Dr. and yours. Over to Mahesh.
Yeah, it's my pleasure again now to introduce another well-known, renowned surgeon, Dr. Randall Wolf. Is a surgeon.
Dr. Randall Wolf hat die Bildschirmfreigabe gestartet.
Yeah, Dr. Randall Wolf is a surgical innovator who since 2000 has been a pioneer in minimally invasive surgical treatment of atrial fibrillations. He's performed over 2,000 Wolf mini-maze procedures since the first one in 2003. He is currently a member of the DeBakey Heart and Vascular Center at Houston Methodist Hospital in Texas Medical Center. Wolf was the first North American heart surgeon to perform the Da Vinci cardiac surgery. He has served as a professor of surgery at Ohio State University and also the Department of Biomedical Engineering. Dr. Wolf has served as president of both the ISMICS and also the 21st Century Cardiothoracic Surgery Club. When not in the operating theater, he is either busy lecturing or working as a magician and a member of Academy of Magical Arts. Interests and subspecialty are minimally invasive atrial fibrillation surgery, robotic assistance in minimally invasive heart surgery, minimally invasive coronary artery bypass surgery and valve repairs, video thoracoscopy, video assisted thoracic surgery, lung volume reduction for emphysemas, etc., and pacemakers. Yeah. Over to Dr. Wolf, please.
Well, it's morning here and evening there and afternoon in Europe. So welcome everybody from different time zones. Hugo, thank you so much for the opportunity to share my experience with you. And for the panelists, it's my pleasure to present to you and to the young surgeons. I miss coming to India in person. I've had 6 great trips to India, and I've operated from the north to the south and east to the west. And I know the quality of cardiac surgery in India is fantastic. And I look forward to joining you all again, hopefully in person sometimes once things settle down. And I'm very sorry to hear that it's a very tough time in India right now. I think you're going through what we went through here in the United States about 6 months ago. And the good news is eventually it'll settle down again. You can see my slide here. I've learned some things just from doing these procedures for over 16 years. I just got a letter yesterday from one of my patients. He said, thank you for doing the mini maze. I've been off blood thinners. I've had no AFib, and I've been off all medications since the mini maze. And then he said, you did my mini maze in 2004. That's 17 years ago. He's now 92 years old. So we're now seeing some very long-term results with these procedures. And the good news is the patients continue to stay AFib free. And I think Nico showed one of the slides that showed there was good long-term outcome with these procedures. The other part of this slide shows what patients want. And it's pretty much in order of importance to the patient. One of the most important things patients want is to get off blood thinners for various reasons. Secondly, they're worried about strokes. And then thirdly, they'd like to be in rhythm. So one of the things that we do very well as surgeons is close the left atrial appendage. And this covers the first two hopes and dreams of patients that have AFib. My disclosure is I'm inventor of some of the AtriCure products. I continue to work with the engineering product development team, and we routinely still do lab work about every quarter, working on new devices and evolving some of the other devices. I'm at the Bakey Heart and Vascular Center in Houston, Texas, at the Texas Medical Center. And my experience has been over 2,000 AFib patients, and we've got it down to science. The patients are not in the hospital very long. This is a pilot skydiver who was bothered by AFib. He did not want to take blood thinners because he skydives. And unlike Europe, as Nico mentioned, in Europe, it's difficult to do patients who've not had a catheter ablation. In the United States, the patients can decide if they want to go with a minimally invasive surgical approach as opposed to initial catheter ablation. This gentleman chose that, and he sent me this video about 9 months after his meeting. That's him jumping out of a plane, skydiving about 9 months after the mini maze, and he's on no blood thinners, and you can imagine he was kind of concerned about doing this, being on blood thinners. He's now about 3 years out from the mini maze and continues to have no AFib, and he's on no medications. How do I know that? Well, in almost all the patients, we put a link in after the procedure, so we have objective evidence of whether they're in rhythm or not. From a historical standpoint, this clamp turned into what's known as the AtriCure device, but this was the very first one. This is from my lab at Ohio State University back in 1999. This is acute porcine lab. And here you can see a modified SEM clamp. We put electrodes on the SEM clamp, and we demonstrated that we could very nicely get around the pulmonary veins in the animal model. And what we found was that we could get a transmural lesion on the atrium in about 12 seconds, but it's not a time device. As Nico mentioned, it's based on impedance or the inverse of impedance, which is conductance. But the general overall plan is to do this. So if there are AFib foci around the pulmonary veins, this clamp is very effective in making a transmural lesion in a very short time, as you saw on the previous video. And it truly is a transmural lesion, but it doesn't destroy much left atrium. I think that's important. It makes a line. But the left atrium, for the most part, is intact. We're not destroying heart tissue. This is some of the original studies I did back in 1999. And this is the inside of the pig heart, even though the clamp was applied on the outside of the pig heart. Because it's a clamp, there's no heat sink from blood when you close the clamp, and you get a beautiful circle on the inside of the pulmonary veins as well as the outside. And on trichrome stain, you can see that as well. As Professor Dahl noted, there have been lots of energy sources of all these mentioned on this slide. Microwave went by the wayside. HIFU, high intensity focused ultrasound, no longer available. Laser went by the wayside, and we're left with these now: monopolar RF, cryotherapy, bipolar RF, and electroporation. This is true both on the surgery side and the catheter ablation side. And electroporation is very exciting, and the frog may jump, and that may be where we're headed. We are currently doing laboratory work for the surgical part of electroporation, and there has already been a clinical trial in the United States with electroporation, both for surgery and catheter ablation. The first cases with the clamp were in Europe, in Leiden in the Netherlands. We did open concomitant cases. And then AtriCure started as a spinoff of Enable based on that clamp design. My own experience, the first, what became known as the mini maze, we performed in 2003 when I was at the University of Cincinnati. And that's my mentor, John Flagey, looking over my shoulder. You know what it looks like, because Nico showed a very nice edited video of it. This shows the outside. The cartoon shows the general approach between the ribs. We can see the veins very clearly. We can make a transmural lesion. We can see everything, and that's one of the advantages of this approach. I do want to emphasize a couple of things. One is we always close the appendage, and that's important. And two, we also do a partial cardiac denervation. And I think that's extremely important. I'm not going to show much of this because I think the video you already saw was illustrates the main points of what we do. But this is sort of the picture you see on the right. You can see the phrenic nerve posteriorly. We can avoid that. In over 2,000 cases, I've not had any phrenic nerve injuries. You can see it clearly and you can avoid it. If we go to the next video, I will show this because the clip I use is a little bit different than the one Nico showed you. And this can be done as part of the mini maze, where it can be as a standalone, just to close the appendage. This is the Pro V. This is also an AtriClip. And we can see the appendage very clearly. We can make sure it's completely in the jaws of the clamp. And we also have transesophageal echo control while we're doing this. In the background is the pulmonary artery. We're underneath the pulmonary artery. We're right at the base of the appendage. There's no question we're getting the complete appendage. We can see everything. We can do everything clearly. In this part of the procedure, or as a standalone procedure, this takes about 30 minutes in the operating room. It's a very effective way to close the left atrial appendage. And as opposed to a Watchman device, we are also electrically isolating the appendage. The Watchman does not electrically isolate the appendage. There have been many cases over the years where 3 or 4 beats after I place the clip, the patient goes in sinus rhythm. And I don't think that's just serendipitous. I think sometimes the macro reentrant circuit includes a part of the appendage. And once you eliminate the appendage, you eliminate that loop and the patients go into sinus rhythm. This is not new. Closing the appendage was first reported by an American and by Dr. Madden in 1960. That's back when the LAA was called the left auricular appendix. Initially, it was called the appendix. And also it was emphasized by Dr. Johnson from the United States. The left atrial appendage is perhaps our most lethal human attachment and should be closed whenever it can be closed. So close the left atrial appendage. It eliminates the need for blood thinners. So even if you're out of rhythm, your incidence of stroke has gone dramatically lower. And this is my summary slide on the left atrial appendage. It's important for 4 reasons. And that's if you close it completely. Watchman doesn't do that, but the clips do. You decrease the chance of stroke. You can stop blood thinners. As I mentioned, you can also decrease the AFib focus in some patients. And then lastly, as some recent publications have shown, blood pressure control is much better. In our experience, in the order set, post-op order set, after the mini maze, all blood pressure medicines are cut in half, and no blood pressure medicine is given if the systolic pressure is not greater than 120. Most of the patients who have this procedure get off all their blood pressure medicines, and it lasts for a long time. So there is something about closing the appendage and changing high blood pressure and the need for blood pressure medicines. The other thing I'd like to emphasize is that I believe most patients with standalone AFib start out with vagal AFib. And this is produced by the autonomic nerves around the heart. These are mixed sympathetic, parasympathetic nerves. They also innervate the stomach. This is a diagram to the left here that I produced in a paper, 10 years ago. And these are where the GPs tend to hang out. I test these areas on each patient. How do you test these? You simply take the pen that Dr. Dahl showed you, and you can do high frequency stimulation in the fat pad. This is the Waterston groove area. And when you hit a ganglionic plexi, the heart will stop. You'll have a diastolic arrest of the ventricle. As soon as you stop stimulating, the heart starts beating again. And we ablate these areas, we test until the heart no longer has a diastolic arrest when we stimulate these areas. You can also herniate the Waterson groove fat pad into the clamp, which I do routinely, and it takes care of most of the levels except level 9, which still sometimes has to be touched up with the bipolar pen. There's an analogy to this. In the 1960s in the United States, the most common operation was for stomach ulcers, and it was to cut out part of the stomach. But we learned that if you simply cut the branches of the vagus nerve going into the stomach, you effectively decrease the acid production of the stomach. Now, today, there are other ways to decrease acids in the stomach. But my point is, I think we have an analogous situation. In my mind, AFib starts with the autonomic nerves. That's another reason why I think the clamp works so well. The nerves are epicardial. The clamp treats the epicardial nerves. And it could be, we'll see in the future, but I believe we'll find out that burning up or destroying heart tissue is really a poor substitute for interrupting the focus, which are the autonomic nerves. And even many electrophysiologists will acknowledge you see this map to the right, where the ganglionic plexi are located. This includes the ligament of Marshall, and there are some approaches, including an EP in our group who uses alcohol to obliterate the ligament of Marshall, because we know these areas are important. And look where these GPs are. They're right around the pulmonary vein. So I'm not sure it's the muscle that stimulates the AFib. I believe it's an imbalance of the autonomic nerves. The first article, what we started, was called Video-Assisted Bilateral Pulmonary Vein Isolation and Left Atrial Appendage Exclusion. This was back in 2005. It was a patient who named it the mini maze because he said, "Doc, you cured my AFib and you're not going anywhere with a title like that." So he named it the mini maze and started a website. The first mini maze patient, 12 years later, no meds, no blood thinners, sinus rhythm. Now here's the other really important point besides the GPs I wanted to make. I see a lot of patients. I do about 3 to 5 of these procedures a week. So I see a lot of patients that have had multiple catheter ablations. And if I look back to the EP reports on the second ablation, on the third ablation, on the fourth ablation, the pulmonary veins are isolated. We're going to work on this area, the left atrium, or that area, the left atrium. This is a patient who's had 3 ablations. And same thing, the veins are completely isolated. Guess what? They're not. When we put the pen down, like Dr. Dole showed you testing, the veins are not isolated. They're isolated from the inside. There's an S-scar, there's a scar on the inside. But from an EP standpoint, this is a false assumption that you're transmural. You're not. All these patients do not have 4 vein isolation of the pulmonary veins, even after 5 and 6 ablations. Now you can see here on the slide, there are areas where there's a transmurality, but I've never seen all 4 veins completely isolated after multiple catheter ablations. And this is not a dig at EPs. This is a dig at the technology that's available. The technology that we have suggests that there's no signal in the pulmonary veins after a catheter ablation. But time and time again, every week, when we touch down on the outside of the vein, there's still signals going through. So the first thing that I do for left atrial fibrillation or flutter, left atrial flutter, atypical flutter, is we still isolate the veins because the veins are not isolated. And once you do that, these patients do great. Here's an example. This is a patient with 3 ablations. We have a surface ECG on the top. The second line is touching down on the right superior pulmonary vein. There's still a signal there after 3 ablations. It's also in the bifurcation. It's also on the inferior. We put the clamp on, and here you can see I've surrounded the ganglionic plexi as well. I think that's very important. And that's in the fat pad there. We also make another line closer to the pulmonary veins, but still on the antrum. So my lesions look like this. This gets most of the ganglionic plexi. And then we test again. Now look at the second line, which is the direct touching down epicardially on the right superior vein. It's flat. The bifurcation's flat. The inferior vein's flat. And that makes a difference. So those are two important points, things that I've found over the last 16 years. I do use a link in almost all patients, unless they've already have a pacemaker or they absolutely refuse it. But 95% of the patients have a link. We're putting together a manuscript now on 3-year follow-up of mini-maze with the link, both for paroxysmal, persistent, and long-standing persistent. And the preliminary numbers are very good. In fact, they're similar to a Cox Maze 4. This was a study that we did some years ago, and you can see our numbers were good, both for paroxysmal persistent and long-standing persistent. And the candidates for what I do, it doesn't matter what type of AFib it is. It doesn't matter if there's been a previous ablation or a stroke, or they can't take blood thinners, because we use no blood thinners after the procedure. Many of these patients have also failed antiarrhythmic medications. This is a nurse who had 3 failed ablations. She was told she needed a pacemaker and AV node ablation. That didn't sound very good to her. She had the mini-maze. She's from Wisconsin. She came to Houston, had the mini-maze. She's now 4 years out. She's had no AFib. She's on no medications. And her pulmonary veins from the outside, from the inside, they were isolated, but from the outside, they were not. So putting the clamp on in patients who've had previous ablations is very useful. This is a study we did of about 100 patients looking back out to 6 years. You can see that most of them, regardless of the type of AFib, were in rhythm. Most of them were off antiarrhythmic medications. And the quality of life was tremendously better after the mini-maze versus before the mini-maze. Here's another patient, 11 years out, been AFib free for 11 years after the mini-maze. What's on the horizon? Pulse field ablation is probably going to be the next big thing. I'm also working with a company where we're doing cardioversion with minimal energy. We're able to change the rhythm in the animal from AFib to sinus rhythm. We just did another porcine study this week with 0.2 joules. You heard me right. We're now able to get the animal from AFib back into sinus, a cardioversion with less than 1 joule. And we believe that in the future, this may be a way to cardiovert patients without even sedation. And maybe the patients will be able to cardiovert themselves in the future. Electroporation could be the next big thing. There is also a push. There's some studies with radiation therapy to treat ventricular arrhythmias with some initial excellent results. There have been some attempts to treat AFib with radiation therapy as well. And there are many companies working on ways to allow the EP to treat the posterior left atrium without injuring the esophagus. And in my own opinion, I suspect that the convergent technique that Dr. Dole showed is a permanent solution to a temporary problem, because I think in the future, we're going to get around that business of avoiding damage to the esophagus in other ways. The radiation therapy is using the CyberKnife, by the way. Another thing that I've found in some of these young patients, they've been misdiagnosed. So it's very important to properly diagnose the arrhythmia. In some young patients, they may have inappropriate sinus tachycardia that's been inappropriately diagnosed as atrial fibrillation. So be very careful about what you're treating. And the other point I'd like to make of my experience, as I mentioned before, traditionally, cardiac surgeons have been not very good about following patients. Usually the patient goes back to the cardiologist. But the only way that I've learned from my experience is to follow these patients myself. And like Nico, we're very aggressive. I put a link in, I follow all the links myself. If at 1 month they're not in rhythm, we do a cardioversion. And our treatment is very similar to Dr. Dole's, and patients who 6 months to a year out still have some arrhythmia, and it's usually flutter, it's not usually fib. We're very aggressive about going back with a catheter, and it has been absolutely amazing. A follow-up catheter procedure after the minimally invasive approach has been tremendously successful. At Houston Methodist at DeBakey, we have nobody that's not in rhythm after their follow-up catheter ablation. I work with Dr. Fahed, who's an EP at DeBakey, and he tells me it's 100 times easier to go back on one of these patients and find a spot that's maybe outside where we worked. So we're very high on a hybrid procedure, but our hybrid procedure is do the surgical part first and then follow up with the catheter. And it makes the catheter part much easier, and it's been tremendously successful. So in conclusion, the combination of a bipolar clamp and going to the source of the problem, which I believe is denervating the ganglionic plexi, and closing left atrial appendage really works. It's durable out to 16 years. Eliminating the left atrial appendage through a minimally invasive approach is extremely effective. These patients are mainly so happy because they don't have to take blood thinners anymore. And I've found that of all the patients I've treated as a heart surgeon, the atrial fibrillation patients are the most grateful patients a physician could ever have. But I would implore the physicians in India, the cardiac surgeons, follow your AFib patients. There have been many patients that they're just left on amiodarone. Nobody checked up on them. They're on amiodarone a year later, and you go, why? Well, nobody told me to stop it. So you've got to follow these patients closely. There have been patients that are in AFib a month after the procedure, and they haven't had a cardioversion yet. The cardioversion is very successful after a minimally invasive procedure. So these patients must be followed slowly. The last comment I'd like to make is not that important, but anybody who follows these patients a lot will know that there are many different types of long-standing persistent patients. There are patients that have been in paroxysmal or persistent atrial fibrillation for 10 years. They've only been continuous AFib for 1 year. By definition, they're long-standing persistent AFib. But that's a lot different from a patient who's been continuously out of rhythm for 10 years. So please, surgeons, take a good history. If the patient's in continuous AFib, determine how long they've been continuous. In my own practice, if they've been continuous for less than 5 years and their left atrium is less than 5.5 centimeters, they still do very well with a minimally invasive procedure. So find out how long they've been long-standing. All long-standing persistents are not the same. And what I found, this was in an article that was published in Houston, but what I found is these patients want hope. They've been told by their physician, perhaps their family physician, perhaps their internist, sorry, you're on blood thinners for the rest of your life and you're out of rhythm for the rest of your life. You just have to deal with it. And what we tell them is, in some cases that's true, but in many cases it's not true. And if you give them some hope, that's the first step of making them feel better. And their hope turns into happiness. So we can still make a lot of patients happy. And in the end, as physicians, that's what we should be trying to do. Give patients hope and make them happy. It's been a pleasure presenting to you all, and I look forward to any questions. Thank you very much.
Thanks. Great, Randy. This was just appropriate for our audience because this is a society platform, and you had greatly convinced our society surgeons that we can treat this even though it looks like a persistent. Now, issue which one has to highlight here is that given a situation, patient has got a standalone AF. In your practice, is that patient first goes to the electrophysiologist or goes to the surgeons for procedures? Or is the surgeons If they receive first, they take opinion of heart team and accordingly decides. What is the practice and method is?
Okay. Well, in my own practice, I see patients from all over the country. Patients this week came from Washington State, one came from Wisconsin, one came from Florida. And generally, these are patients who have decided they think they would do better with a long-term, in the long term with a surgical approach. And they've made a decision that that's what they'd like and their insurance covers it. Now, my own hope and dream would be to have a comprehensive center. And that's what I think would be a fantastic option in India, where you treat everybody that has an arrhythmia in a center. And I think these are going to pop up in Europe as well. And then you do what's best for the patient. And we've been through this in bypass surgery. And in Europe, many years ago, when I attended a conference, there was a conference on each patient this was in the Netherlands, in Groningen, where they said, okay, this patient has coronary disease. Should we do a bypass? Should we do a stent? And the surgeons and the cardiologists sat in the same room, and they did what was best for the patient, not what was best for the surgeon or the EP. And we're not there yet in the United States doing that. Generally, patients go for what they've been told they should go for. But what I find is more and more patients are doing their own homework. They're getting online. They're finding there are other options for them, and they're thinking it over and they're making their own decision. So right now it's segregated to some point. I see patients who do their homework and they're more informed, but hopefully in the future, this will be a center and will make the best decision for the patient.
Thank you. Over to panel.
Yeah, first of all, thank you very much. Wonderful presentation. I don't want to make it a EP versus surgeons, but you see, when you made a comment in between that you never saw an properly isolated pulmonary vein, that's not probably correct, because in patients who have recurrent
No, I didn't say that.
recurrences.
I didn't say that. I said never saw 4 of them.
Exactly. I mean, those you operated. I mean, there would be a lot of. Pulmonary vein isolation is a very standard procedure and a very good success rate. And particularly with all the new technologies, whether we do RF or whether we do cryo, it gives very good, in most cases, it will give good isolation. So there would be recurrence in 20-30% patients, and patients who have repeated recurrence obviously will go to the alternative approach, and you may find them they are reconnected or not properly connected. But that's one thing which I wanted to make. But as you would agree that transmurality is the main problem, whether we do catheter-based approach or whether we use surgical approach, transmurality, you cannot always ensure that if you use an atri clip, or whatever, clip out from the epicardial, you will always achieve transmurality. It may never happen. Of course, the incidence may vary depending on the technique you use, but it's not that epicardial or endocardial will always achieve transmurality, because that's the main problem with AF ablation, or whenever we want to isolate pulmonary vein. So that's another problem. Thirdly, in India, we have a lot of patients who have rheumatic atrial fibrillation, and doing a standalone procedure in them may be especially more difficult, because it may not always remove the need for anticoagulation. Especially if you isolate appendage, because there is data from India which suggests that at least 20-25% clots may not be in the LA appendage. So just removing LA appendage, while it may help certainly bring down the incidence of stroke or thromboembolism, it may not totally eliminate the need for anticoagulation, at least in the rheumatic population. In non-rheumatic, it's okay. So these are the 3 comments I wanted to make.
Well, I'm sorry if I didn't make it clear, but my comments are based on minimally invasive AFib surgery in patients who have lone AFib. These are not rheumatic patients. These are not patients with mitral disease. So certainly your comments are.
I would agree with that.
As far as the animal studies that I've been involved with, the transmurality using the AtriCure bipolar clamp have been 100% transmural in all animal studies. So we know that for sure.
Dr. Wolf, that was a very exciting presentation, and I'm quite impressed with your clinical results, and also impressed by the way you monitor your patients post-operatively using your link. And I actually was quite excited about your theory of vagal induced atrial fibrillation. And I would certainly agree that at least in younger patients, that's one of the predominant causes of atrial fibrillation, especially if you do not have any other comorbidities or risk factors for AF. And history, actually, if you take a good history, that sometimes that also helps in confirming this mechanism of AF. Patients may present with history of AF, which starts after an episode of vomiting, or starts in sleep when their rate slows down, or they have Holters where you see that after bradycardia, the atrial fibrillation starts. And your approach that you said was pulmonary vein isolation, which also is the same area where ganglionic plexi are present. And this has been shown during endocardial ablations as well. And many of times when we do ablate, we do also find the same phenomena of ventricular asystole. And in fact, we need to pace the atria so that we can continue the lesion. And but the other comment is that I agree totally. One should not get the message that after removal of left atrial appendage, you can stop blood thinners in all patients, especially in Asian and Indian patients where rheumatic incidence is quite high. It is in fact a requirement of lifelong requirement of anticoagulation. And though many of our surgeons also do not believe so, but we do a lot of patients who come with stroke or thromboembolism once their oral anticoagulation had been stopped. So this message should be very clear that in rheumatic patients, especially lifelong anticoagulation is important, whether they underwent MACE procedure, AF ablation procedure, or removal or exclusion of left atrial appendage. Thirdly, I would like to hear your comments about the newer thing that is coming with management of AF, that is lifestyle modification and treatment of sleep apnea. And so what is your strategy? When a patient turns to you and his lifestyle is not very good, do you advise to give the patient time to improve their lifestyle, treat for sleep apnea, or you do ablation first and then ask the patient to follow these guidelines?
Okay, well, I thank you for the kind comments. I certainly agree with you on the fact that rheumatic patients are a different subset. Absolutely agree, and that's important. Well, I look at the BMI on every patient. So I look at their height, weight, calculate BMI, and based on that, I have a talk with the patient. And if their BMI is over 37, I tell them, look, if you want to go through all this and you really want to live a long time, you need to have a come to Jesus talk and understand that unless you lose weight, we're not going to reach our goals. So that's, and in some patients, I delay their surgery 6 months until they lose weight or have some procedure to lose weight. We do that too. We also, in the history, and I didn't mention this, and thank you for bringing it up, another important part of the history is a history of sleep apnea. So if the patient has a significant other or wife, and they don't know if they have sleep apnea, I ask them, or the husband, does this patient stop breathing at night? Oh, yes. You know, if we get any positive history and they have not been evaluated, they must be evaluated for sleep apnea before we proceed. We know from some studies that the recurrence rate for catheter ablation or surgical ablation is probably 40% higher if their sleep apnea has not been adequately treated. And we start the BiPAP and the CPAP, whatever they're on, immediately after the procedure during the day, because they recover so much faster. I tell them, you don't just put this on at night. After surgery, put it on. If you're watching television, put it on. You're going to recover faster. So you're right. It's very important and is an important part of our history.
Great. Thanks, Randy. Please do stay till the end. there might be some more questions. Let me welcome the ISMIC's president. Thanks, Peter, for joining us. And now over to the Dr. Mahesh for introduction to our next speaker.
Thank you.
Yeah, it's my privilege again to introduce Professor Dr. Piotr Suwalski, who is head and professor of the Department of Cardiac Surgery at Warsaw, Poland. He is a member of the EACTS Techno College on Task Force in Arrhythmia Surgery, ex-member of the EACTS Mitral and Tricuspid Valve Surgery. And
Dr. Suwalski hat die Bildschirmfreigabe gestartet.
He's the current president of the ISMICS from 2019 to 2021. He is president of the Cardiac Surgical Working Group of the Polish Society of Cardiology. He is currently the Secretary General of the Association of Polish Cardiac Surgeons. His focus is mainly minimal invasive and robotic cardiac surgery, arrhythmia surgery, left atrial appendage occlusion technologies. Over to Professor Suwalski, please.
Yes, good day, everybody. Thank you very much to the organizers and especially to Dr. Professor Yugal Mishra and to all organizers. It's my great privilege to be part of SMICTSI, and thank you very much for this kind invitation. For that, so again, thank you very much for your kind invitation. It's really a great pleasure and honor to me to be here. I remember our physical meeting, which I miss very much from I think 2 years ago in Mumbai. It was fantastic. So I'd like to also share and convey best greetings to you from all officers and members of ISMICS. So I first of all, I try not to overlap my esteemed speakers that have talks before. So I will try first of all to say a few words on the research that we have done in recent time on very long follow-up of the concomitant ablation. Then I will try to say a few words on a hybrid approach, but not only to AFib, but also to other arrhythmias, and maybe say a few words on left atrial appendage occlusion in our surgical setting. So just to go forward, of course, we have a few data showing actually on big numbers of patients that there is a huge impact of atrial fibrillation on our surgical patients, like this paper in cabbage patients. What is also very interesting in terms of long-term follow-up, what is interesting, but that's you can see here on the right side that in fact if you perform an ablation, a patient goes back to the survival curve of the general population. These are unfortunately smaller studies, usually single center studies. But what has also inspired us to perform our research is that analyzing the STS data database for other reasons, actually, for a risk model, Dr. Rankin has revealed that in fact, if you perform an ablation you cannot even make a patient come back to normal survival curve, but even improve the survival comparing to healthy patients. So so equal survival, I would say. So just few words. So it inspired us to have a look at the Polish National Registry, which is actually one of the oldest in Europe. And there are a few 100,000 operations inside done over the last almost 20 years. And what is also very important is that this is very well validated longitudinal survival, since we are getting every few months, every quarter, governmental central data of the long-term survival. So so that's why, first of all, we try to look into what's happening with the mitral patients after concomitant AFib patients after concomitant ablation. So we had a look at the almost more than 34,000 patients. So, and finally also, and then you see that the whole tree here. So, and so we focused on 11,000 patients, and then we performed the propensity score matching in almost 2,000 pairs. So, so this is a busy slide, but generally it's just to show you that we were really able to make this propensity score in a very deeply in lots of factors, and we could reveal that we have almost 40% of survival benefit in those patients when you compare patients, mitral patients with atrial fibrillation, when you perform ablation versus when you leave it alone. As you can see, this is up to 12 years of observation. So this is, I think, very nice data. And what is more, the in-hospital early and postoperative and in-hospital mortality was also showed that there is no influence on of the ablation itself. So what is also interesting that we could see that the highest benefit was in younger and lower Euroscore patients. And but still there was benefit in patients with comorbidities like diabetes, kidney disease, COPD, and so on, irrespective of mitral valve pathology, and less benefit with older patients with poor mobility, lower ejection fraction. Of course, there were some limitations typical for retrospective registry analysis. Another paper that we have done right after it was we looked the same into a cohort of coronary artery bypass surgery patients, and we could find it was a propensity score 2 to 1. But we worked in almost 8,000 patients with CABG and yes or no ablation in atrial fibrillation. So what we could see was almost 30% of survival benefit if you perform an ablation over 12 years of observation. So what was also interesting that, but actually made very logic, I would say, was that there was a better benefit if you in patients in whom the ablation was performed in on-pump surgery. This is for me because, in my opinion, due to the fact that you're able to perform a more vast maze-like or hopefully maze-free, maze-4 ablation. And also in patients with no total revascularization, which also pathophysiologically makes sense, and also with free vessel disease. So just to not to be so we have published similar subgroups. Some other did some other research. So I don't want to talk. It's a similar result. So whichever group we have looked into, we saw an impact of ablation, a long-term survival benefit. And also in this particular group, as I mentioned, in on-pump, due to simply better ablation that was possible. Okay, and this is the whole cohort, and also showing about 30% of survival benefit. So more or less at the same time, Dr. Rankin has published similar data, which really made us happy because it's very, very similar results from the STS database and his database. and showing also 29 reduction of mortality over, in this case, over 2 years. So, but also a very nice cost effectiveness. I think the very strong part of this paper was cost effectiveness calculation, which is favoring ablation. Okay. Also, in one of our papers, we could show that that the centers with better volumes of surgery are also more prone to perform ablation, which shows very much that a role of education and role of such societies like SMICTC, like ISMICS, like other societies, also to encourage surgeons to perform ablation, concomitant ablation, and give the patients that benefit. So, and this, as you can see, it's still needed to be done in especially in groups like CABG, where we have the biggest discrepancy between the percentage of ablation done versus no ablation. Okay. So then I'd like to say a few words about hybrid approach to arrhythmias, which I like very much. And of course, this is quite clear that especially atrial fibrillation is a very complex arrhythmia. And of course, also we surgeons, we also leave some failures behind. So so it's very interesting to have a friend and bilateral partnership with our electrophysiologist in order to reaching out to the best result a patient can get. Also, we know there is maturation of the scar, very interesting phenomenon, which can be also followed by using our partnership. So as you can see, there are some interesting papers showing that that are some areas especially as far as we talk about AFib in atria, especially the dome of the left atrium, as you can see, where ablation is more or transmularity of ablation is more difficult to reach. So, so this is my friend electrophysiologist with whom I work, Professor Stets, and this is also one of my favorite albums from Stan Getz, The Best of Two Worlds. So with João Gilberto. So I think this is actually a nice motto to summarize why this partnership is very beneficial for a patient, because we surgeons can offer a patient quite a few interesting and very strong advantages, especially mainly which are anatomically driven. On the other hand, EP cardiologists can offer electrophysiologically driven maneuvers, and of course, when you match those best of two worlds, as I mentioned, it can be really beneficial, especially in difficult clinical situations. Hybrid, it can mean also naturally single step or two-step approach, but also, for example, there are also studies with two-step within the same hospitalization. Usually, it also depends on the type of reimbursement in a particular country. This is the transgastric or transdiaphragmatic approach, as we all know, which is also an example of hybrid approach. Especially this one is interesting because it wouldn't make sense if you perform only surgical or only electrophysiological or percutaneous part, catheter part of ablation. Which has a nice long-term results. There is also a new one which is now spreading in the world. It's actually a bit, I would say, simplification of this transdiaphragmatic approach. which is called sub-X. So when you go with this tube directly through the subxiphoid space, well, maybe it's not very very elegant in terms of having beautiful endoscopic procedure, but I think it really makes sense because this is very standardized and relatively easy procedure. And as we can see, still, this is STS database, we can see that still over years, the number of standalone procedures, because of their complexity usually, and thoracoscopic, the requirement of thoracoscopic skills is stable. It's not going up like other types of surgeries. So, there is a number of I would say classical papers on the hybrid approach that showed very high. This is from Brescia group that showed very high efficacy of the ablation. You can see here the types of the catheter based touch-ups that had been done in this particular group a few weeks after the first part, which was the box lesion. This is also a quite well-known partnership between EP and a surgeon, Laurent Pizot, and Marc Lamer, and from Belgium. And this is the single-step approach, which is, as you can see, it's a pretty complex protocol, but nevertheless, they were able to see improvement, especially in those more resistant patients, long-standing persistent atrial fibrillation. Also, this is the review and the meta-analysis from 2019, showing that generally, as you can see, this is hybrid versus catheter, that it was 70 versus 50% of efficacy in favoring the hybrid approach. Of course, there were some luckily not some minor complications, more complications on the hybrid side, which of course was something to be foreseen. But still also the difference in efficacy was pretty significant. Nevertheless, if you see the breakdown of the complications, it was usually transient and not deadly. So again, similar analysis, and also showing you usually the locations of catheter touch-ups after thoracoscopic surgery, which was pretty similar to the one that I have shown you before. But also here is the hybrid papers are put together, and as you can see, the safety profile is very, very nice. I think we have Professor Doll here, and Professor Doll is a principal investigation of the CZAF trial. So I hope soon it will be revealed. The recruitment is already done, and I think there will be quite a number of interesting answers given. This is randomization between catheter and hybrid ablation. So I'm looking forward to seeing the final results of this trial. This is just an example of one stage hybrid approach, thoracoscopic, and as you can see on the right hand side, we were also able to to connect the surgical electrodes to the EnSite system, so that you can even see them in the EnSite map. So it really helps, especially in resistant patients having a complex background of the atrial fibrillation. So especially when this is so my partner Professor Stetz, he usually does not use he performs no fluoroscopy approach. So it really also improves the whole feasibility of the procedure. But you can also use those approaches for other arrhythmias, like generally VT with electrical storm, or WPW or Brugada syndromes. Sorry, it's partially in Polish, but this is where we use also sympathectomy, thoracic sympathectomy for channelopathies, like you can see here, very specific diseases like long QT segment syndrome or electrical storm, VTVF, Prince-Metal disease, Takotsubo with VF, other things like also concomitant AFib ablations with Raynaud's syndrome or hyperhidrosis. These are, of course, very selected patients and not big numbers, but still it's good to have such a partnership within the heart. This is the WPW syndrome operation, of course, again, which was very resistant to few trials with the catheter, and this was found using NSIDE system, and then cryoablated. It was just below the right coronary artery. And this is a hybrid approach to Brugada syndrome. This is, as you can see, thoracoscopic approach to the RVOT, and then we perform either bipolar or transpolar RF, or sometimes cryo. Of course, again, these are usually patients after a few unsuccessful catheter trials. Okay, and this is an example of thoracoscopic thoracic sympathectomy in the cases that I have mentioned before. So we usually do it bilateral. This was the lesson from our first cases, because it can come back. And this is an example of after Brugada syndrome. My friend Sebastian Stedt says that even a cardiac surgeon can see the difference how the ST segment looks like in this ECG. So this patient, we have already a long follow-up of him. He's totally cured. In this particular patient, we also use something like cardio-neuro-ablation. So we also checked up the nervus vagalis, or the vagal nerve, with imelin, and so it was also a special touch-up with cardio-neuro-ablation in this particular patient. Okay, so we also in some patients what we perform, it's a procedure called mini champs, which is a combination of all of those different sympathectomy, and also vagal nerve, and other parts of complex ablations, epicardial and endocardial, in very complex patients. And this is, again, it was done sympathectomy, for emergent sympathectomy, for electrical storm. This patient was reanimated a few times a day, even on the table while doing it, and it was last resort to do it. So and it luckily helped. Okay, so maybe I will just say a few words now about the left atrial appendage occlusion, if you don't mind. Just finishing off my presentation. So first of all, we all know that the left atrial appendage is was called the most lethal human attachment by Dudley Johnson. It's due to, of course, being an origin of the majority of the thrombotic material, especially in cerebral stroke. The weaknesses of the surgical closure of the left atrial appendage were for stapler, were remnant, and also from our experience, we had 1 or 2 bleedings, unfortunately. It has to be said. And on the other hand, for endocardial closure, exclusion with a continuous suture, there is a problem of persistent flow or recurrent flow after some time back into left atrial appendage. So this is an example of stapling, and as you can see, there is a remnant here. Of course, you can deal with this putting another stapler or endoloop or whatever, but this is just to explain the danger that of leaving it behind. On the other hand, especially when you perform the minimally invasive mitral surgery or thoracoscopic mitral surgery, usually we tend to close it from inside. But the problem is here, this is an example of a patient that we did minimally invasively mitral repair, and a few years after he had, the patient had endocarditis, so we reopened him. And this is how it looks like. The suture was not torn, but it was actually just loose. And there was the recanalization of the left atrial appendage. The problem is that if you have the absence of effective ligation of the left atrial appendage, the risk of stroke is up to 7 times higher than leaving it alone. So in fact, paradox here is that if you try to close the left atrial appendage, you really have to do it very well. Otherwise, you put a patient at risk. This is another paper showing that in this paper, it was 5 times greater. So we already have at the moment some data showing that closing left atrial appendage during cardiac surgery gives a reduction of stroke and in this case even death. And this was a nice paper from JAMA. It's a retrospective analysis showing this benefit. On the other hand, we are awaiting for Laos 3 randomized controlled trial, also Atlas trial, that will answer those questions. Few words on AtriClip, which is at the moment for concomitant one of the most popular devices, and it's very universal. It can be used in many clinical scenarios, also as a standalone procedure from open to totally thoracoscopic and so on. We also have, it was recently introduced, this V-clip. I think this is interesting option, especially in those situations. However, I must say this is, of course, an off-label use to close the atrial appendage with the stable distal thrombus inside. So, but this, of course, one has to be very cautious about it. Nevertheless, in some particular cases, it gives that option. The safety profile and efficacy profile of the AtriClip is very high. As you can see, it's more than 90 to 100% of occlusions with a very low risk. And there are also some data showing already almost 90% of reduction of ischemic stroke rate of ischemic events, even with no anticoagulation. Also, if you perform minimally invasive or thoracoscopic mitral valve repair, there is an option to, and this is actually a method of choice in my opinion, how to close the left atrial appendage when you, the best way is when you already clamp the aorta and relieve the blood from and open the left atrium, putting such a suture through the transverse sinus you can very nicely close a left atrial appendage and control it. And then you can see, as you can see, you have a very nice alignment from inside. You can also check it visually from inside. And then this is another case. You can also combine putting an atrial clip with the endoscopic minimally invasive coronary artery bypass grafting, like in this case, using more or less the same 4 ports as you use for the mammary takedown. And this is the Pro 2 device. As you can see, you can put it nicely thoracoscopically and then take down the mammary and then perform, in this case, perform the coronary anastomosis. I think it's a very nice option for very high risk and frail patients who need a triple antiplatelet therapy or triple anticoagulation therapy, and closing left atrial appendage can solve a situation very nicely. And finally, you can also do it in standalone as a standalone procedure. We have just opened also the thorax registry on that. Just in patients, typical high-risk patients, usually with contraindications to percutaneous LAO, or patients, super high-risk patients with intermittent, usually GI bleeding, and because putting this epicardially, you can stop any kind of antiplatelet therapy right away. Okay, this is the one that was done even years after previous cardiac surgery. Of course, it needs a bit more expertise, but it's also doable. And finally, I'd like to say that this is a very interesting option. This is a courtesy from my Finnish friends. They had a very nice study showing that over 10 years after cardiac surgery, elective cardiac surgery, the number of strokes and TIAs is still very high, because this is just the cohort of patients and the profile of patients that we are dealing with in doing cardiac surgery. So they usually have very high CHA2/VASc. So and of course also major bleeds. So and at least half of 1/3 of those events were typically cardioembolic. So basic on this data, they have started, and we have also an honor to be part of the trial, LAA closure, which has a very brave idea, is to this is randomization of patients having the AVR with bioprosthesis, of course, but with the left atrial appendage closure with AtriClip versus no closure, but this is important, in sinus rhythm. So this is very interesting. This is very interesting idea, and of course we need time to collect enough patients, but it can be that it will have also a protective action over long years. Unfortunately, we still have to wait for proper guidelines, because we still need some more data. But I think now, having the LAO-free Atlas trials, maybe we'll have next guidelines will have some more specific guidelines. Finally, we have also submitted from also with our American friends a paper with standalone AtriClip in a typical profile of left atrial appendage occlusion patients. And these were also almost 200 patients, and we can already see some reduction of actual stroke rate versus predicted stroke rate. So we will see how it goes. So thank you very much again, and it was my pleasure and honor to participate. Thank you very much for your kind invitation.
Great, Professor Sivalsky, for your presentation. Now, straightway, inviting panels to discuss this part of the presentation. And to Professor Nicholas Dahl, Randy, anybody wants to come out, and Dr. Prasanna, please go ahead. Dr. Saxena.
Thank you, Dr. Sivalsky. I think that was an excellent presentation, and it's indeed a privilege to listen to all the three presentations. They were truly excellent. And we got to know about an array of new approaches and new technologies. So it's increasingly clear that hybrid approach is the way to go, and there's going to be increasing collaboration between minimally invasive thoracic surgeons and electrophysiologists. We certainly need to spend more time together, and a lot of learning from all three talks. Thank you. Dr. Karthike?
Yeah, I would agree that hybrid ablation is the way to go. It was actually a pleasure listening to all the three talks, and a lot of new things that we learned, and very exciting data also as far as surgical ablation and surgical approach to AF, including for stroke prevention, is concerned. So thank you very much. A pleasure to be part of this meeting.
One thing that I would really, sorry, can I speak?
Yes, please.
One of the things that which I also practice a lot, and which Peter has highlighted, is sympathectomy for VT storm, and especially for long QT syndrome. And we had published our data in the Indian Journal. And our electrophysiologists are so happy with it that it's they immediately send all our their long QT syndromes for this ablation as the primary, sympathectomy, bilateral sympathectomy as the primary modality, even before they consider. So that's an area which surgeons can play a very good role.
Thank you. Thank you.
Do you also get it that way?
Yes. We, of course, these are very selected patients, but I like that idea, coming back to this hybrid approach that was brought up by Dr. Wolf, of having centers dealing with AFib, because AFib it's a kind of I would say symptom, having lots of different, but of course also other arrhythmias. But having lots of backgrounds, usually also they very concomitant to other non-cardiac diseases like hyperhidrosis, or I don't know, or not Prince-Meadows is a cardiac one, but other Raynaud syndrome and so on. So I think such comprehensive units or centers would really improve understanding of arrhythmia, and would really also improve selection of patients for a proper approach from the portfolio in such centers, including more super selected things like sympathectomy. Yeah.
Great. So now we are running out of time. So on behalf of society, I would like to thank our major sponsor and partner, India Medtronics Limited, who has sponsored all these programs. We have already finished 6 modules, but the 2 more modules are going to come. One is on 8th of May, which is transcatheter aortic and mitral valve implantation. The last one is going to be the endovascular stenting of thoracic and abdominal aorta, which is going to be on the 22nd. So with that, let me thank ISMIC's president for kindly coming to this platform, and also that I wish that he should know that in this COVID times we continued our academic activities, and we did these skill development course, and with these 8 modules, and I'm really thankful SMICS for extending our winter the workshop, which hopefully if the things will go, we may be hybrid or virtual. Unfortunately, our SMICS annual meeting is going to be virtual. I don't know what is going to happen in October. If things will be okay, then we may go hybrid or maybe on site. So then I would like to request all the three speakers, Nicholas Dahl, Randy Wolf, and of course, SMICS President, that we will invite officially and we're going to meet in Delhi. With that, also, I would like to thank dear friend Mahesh for taking time to actually introduce all the speakers, to Dr. Saxena, very dear friend and great electrophysiologist, Dr. Karthikeya Bhargav, Dr. Prasanna Simha, and of course, Dr. Prashanta Chandra from Bangladesh. And this was a great event, and SMICS president was present. So SMICS is really thankful for this, and thank you and good night to everybody. Thanks a lot. Thank you.
Good night.
Thank you.
Good night.
Bye bye. Thank you very much. Bye.